So, having heard about the operative management of fractures, it's not just enough. One operates on the patient and gets away. You have got to know what is the post-operative management. Naturally, post-operatively depends upon the type of anesthesia that we give and the type of surgery we perform and the multiple fractures or any other comorbid conditions are there. You will have to plan the post-op management. In this, the immediate post-operative management, let us consider that we are dealing with a case of major fracture, a major surgery has been done, and what is that we have got to do. So, most of the major fractures, especially if they are in the limbs, lower limbs, they require post-operative intensive care unit. That the anesthetist will take care of fluid management, pain management, and then if needed transfusions, etc. So, usually it lasts for about 24 to 48 hours because some of the operations are being done under spinal combined with epidural. So, under these circumstances, if spinal and epidural anesthesia is given until the epidural tube is removed, you have got to keep the patient in intensive care management unit. So, naturally, when intensive care specialists are available, they usually take care of all the necessary things. But as an orthopedic surgeon, we have got our own responsibility. Like, one most important thing is to check for any accidental injuries to nerves and vessels during surgery. Even though it's very, very rare, one should remember this, not to forget about the injury to the nerves or blood vessels which are nearby. So, you have got to go on checking whether the circulation is good distal to the operative site, and similarly the sensations, and if necessary, because the sensations doesn't matter because the patient is already under epidural, but circulation is very, very important, and if only light epidural is there, we can even mobilize the patient quickly post-operatively. And second important thing is, we usually keep a drain to prevent hematoma and subsequent possible infection. So, if the hematoma is there, you have got to look at the drain and see how much of blood is seen in the receptacle bottle, and if it's very high, if necessary, we will have to give blood transfusions. Similarly, the patient is having pain and all that, sedation or increased incremental doses of epidural drugs are necessary, which once again are managed by the anesthetist. And our duty to see that the rest of the limbs, suppose an operation is done in the lower limb, always you ask the patient to move the upper limbs, make the patient sit up within a few hours, and lot of breathing exercise have to be taught. And if the patient is not having pain, then 24 to 48 hours to make the patient stand, and if possible, depending upon the type of surgery, make the patient mobile using a walker for support. So, these things have to be started as early as possible rather than waiting for 2 to 3 days. The earlier you start mobilizing and start the physiotherapy, better will be the outcome. Next is the one about the antibiotics. Antibiotics, some people are being unnecessarily giving too many antibiotics for too many days. So as per the recent standards, the antibiotic is to be given preoperatively 1 hour before surgery. If the surgery is prolonged, second shot of antibiotic, and only 2 or 3 subsequent antibiotics. Then, to prevent DVT, which is a dreaded complication, fortunately in Asian conditions, especially in India, DVT is not that common, but still in major surgeries, better we have got to give prophylaxis for prevention of DVT, that is deep vein thrombosis and pulmonary embolism. So naturally all these things will have to be taken care of in the first 48 to 72 hours properly. Only after the patient settles down in the intensive care unit, the patient is to be shifted to the regular wards or rooms, whichever it is. So then, when to start, make the patient bear the weight or make the patient use the upper limb. It all depends upon type of surgery, type of internal fixation, the strength of the bones. All these things do matter regarding the mobilization. If one is doubtful about the strength of the bone, especially in the elderly, you can start non-weight bearing exercises followed by use of walker for moving around without completely taking the weight on the affected limb. As far as the upper limbs are concerned, unless otherwise, like conditions like segmented fractures and all that, usually we don't immobilize them, and we make the patient mobilize the limb quickly. So basic thing that is required is post-operative management. Number 1, antibiotics. Number 2, pain management. Number 3, fluid management. Number 4, the physiotherapy, which consists of early mobilization, then cardiorespiratory physiotherapy. All these things are essential for good outcome of a case post-operatively. And then the controversy regarding the weight bearing, once again I repeat, depends upon the type of fracture, the type of surgery, and the bone matrix or strength of the bone. So depending on that, usually in upper limbs, we immediately mobilize the things, but in lower limbs, especially about the weight bearing, you have got to have your own standards, even though we can make the patient move about with support without bearing the weight on the affected side. This may take sometimes 6 weeks, sometimes 2 to 3 months also, and in cases like where the fracture neck of femur in elderly, nowadays we try to remove the bone and then replace it with artificial head, which is known as replacement arthroplasty or hemiarthroplasty. Here we can make the patient walk at the earliest possible opportunity. So having said all these things, now finally, when does the fracture unite? And especially if the fractures are internally fixed, compression plates and screws and all that, we can't see the callus in X-rays. The important thing is absence of pain, absence of tenderness, and then the patient's ability to bear the weight without pain. So we have got to judge the patient according to it, but not according to the X-rays. But what are the things to be done as far as X-rays are concerned in case of post-operative fracture management? First X-ray is to be taken on the day 1 itself, because we have got to check your implants whether they are in position or not, or whether the reduction is good or not. All these things can be checked by immediate post-operative X-rays. For our record purposes, also this is very, very essential. So second and third X-rays are to be taken depending upon the rate of healing, that is after 6 weeks, or in between. If you feel that your implants have failed, patient may have pain which was not there earlier, patient may get recurrence of pain and deformity at the site of fracture or tenderness at the site of fracture. All those things indicate that probably there is implant failure. You have got to take X-rays and check up whether the implants are in position or not. So once you are sure your implants have not failed and there are signs of union clinically, you can allow the patient initially partial weight bearing followed by complete weight bearing. This is the post-operative care then one will have to take and think of after major surgeries for fractures. Our duty doesn't end there by just fixing the thing and giving physiotherapy. Very often this should be followed by, if needed, counseling to the patient, patient's relative, because there's a lot of psychological stress following a fracture. So proper counseling has to be done, and in cases where you are likely to have some kind of morbidity for a long period of time, then we will have to advise the people about the occupational therapy also. Somebody who has been very active, running and all that, or a fellow who has been driving a vehicle, very heavy vehicle, he may not be in a position to drive a vehicle. So you have got to think of alternative occupation for him. You have got to give guidance regarding these things also. So a part of occupational therapy also is needed for these patients. Then only the treatment for fractures is complete. So the fracture management is over.